All right, look like we have the quorum. Good morning, everyone, and thank you for joining the Utah Medicaid March DUR meeting. As a few reminder for our meeting today, if you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board member, please reserve your question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendee that are not the member of the DUR board, please enter your contact information into the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And look like our chair, Dr. Cannon is not on at the moment, so I will be chairing until he come up onto the meeting. For the first item of the agenda, it will be the housekeeping items. The only housekeeping item today will be the introduction of Dr. Colby Hancock, our new DUR board member. Dr. Hancock, would you like to introduce yourself to the board?
Yeah, thank you. Sorry for tardiness last month. It was kind of a comedy of errors getting to the meeting. I'm Colby Hancock. I work at Utah Cancer Specialists. I'm their pharmacist in their oral dispensing program. Went to the University of Utah. Been working as a pharmacist for 12 years now, and excited to be on this board.
Thank you, Dr. Hancock, and welcome to the DUR board. We're excited to have you. The next item is review and approval of the minutes. So do we have a motion to approve the minutes? Kumar has a motion. Any second?
I'm Noon. I'll second that. This is Neil.
Hi, thanks, Neil. And all in favor?
Aye.
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 Any abstention? Motion to pass the minute. Look like Dr. Cannon has just on. Good morning, Dr. Cannon.
I apologize for being late. I ended up running from one meeting to the other and got a little bit behind. So good morning, everyone.
Thank you. Would you like to take over? We are at the item number 3 is the review of the DRC for the adult pulmonary arterial hypertension.
You bet. Well, we'll turn it over to the University of Utah for the review of this category.
All right, let me pull those slides up for you here. How is that? Are you able to see those? Okay, so today we will be reviewing the management of pulmonary arterial hypertension in adults with the FDA approved therapies and points for consideration regarding prior authorization criteria. Pulmonary arterial hypertension, abbreviated PAH, is a type of pulmonary hypertension that is due to vasculopathy of pulmonary arterial vasculature. PAH pathology consists of vascular remodeling and endothelial dysfunction. Impaired endothelial cell production of vasodilators has been observed in pathophysiologic studies of patients with PAH, along with overproduction of the vasoconstrictor endothelin-1. These abnormalities contribute to increased pulmonary vascular resistance and thus pulmonary hypertension. The hemodynamic threshold for pulmonary hypertension is a mean pulmonary arterial pressure above 20 millimeters of mercury. For the diagnosis of PAH, this threshold must be met in addition to meeting certain thresholds for pulmonary vascular resistance and wedge pressure that are consistent with precapillary pulmonary hypertension. Going back to the pathology, the resultant ventricular overload due to PAH gives rise to right ventricular remodeling, dysfunction, and eventual failure. PAH has a poor prognosis if not promptly treated. General symptoms of pulmonary hypertension include dyspnea on exertion, fatigue, weakness, palpitations, nausea, and lightheadedness. Progressive symptoms include edema, arrhythmias, and pleural effusion, among others. The incidence of PAH is estimated to be between 5 to 52 cases per million persons based on European registries. Because PAH is a rare and complex, life-threatening disease, ideally patients should be diagnosed and treated at a center that specializes in managing pulmonary hypertension according to clinical guidelines. PAH is classified as Group 1 pulmonary hypertension among 5 classes of pulmonary hypertensive disorders. Within Group 1, PAH is further subdivided into subcategories based on similar pathophysiological etiologies. In countries without endemic schistosomiasis, idiopathic PAH is typically the most common subtype, followed by PAH associated with connective tissue disease, congenital heart disease, portal hypertension, and drug toxicity. Multi-parameter assessment for determining disease severity is recommended by recent clinical guidelines. This includes assessing WHO functional class, exercise capacity, and echocardiographic, laboratory, and hemodynamic variables in order to inform therapeutic decisions. The WHO functional classes are listed here, ranging from pulmonary hypertension that is present but does not limit physical activity to Class 4 with symptoms experienced at any physical intensity level. FDA-approved agents for PAH include prostacyclin pathway agonists, endothelial receptor antagonists, or ERAs, and nitric oxide cyclic guanosine monophosphate enhancers, including the PDE5 inhibitors and the SGC stimulator. These agents stimulate vasodilation through various pathways. The route of administration differs among agents and influences the potential suitability for ambulatory versus inpatient use. For a subset of PAH cases, effective therapy may also include off-label use of a high-dose calcium channel blocker. Each of the reviewed drugs is labeled for the treatment of PAH for a variety of clinical objectives, such as to delay or reduce the risk of disease progression or clinical worsening, to reduce the risk of hospitalization, to improve exercise capacity, and so on. 2 of these agents approved for PAH are additionally approved for non-PAH indications. The inhalation forms of treprostinil have an approved indication for pulmonary hypertension associated with interstitial lung disease. And riociguat is additionally approved for persistent and recurrent chronic thromboembolic pulmonary hypertension. Recent guidelines with recommendations for PAH pharmacotherapy that I will be describing are the 2022 guideline by the European Society of Cardiology and European Respiratory Society, and the 2019 guideline by the American College of Chest Physicians. Generally speaking, calcium channel blockers may be considered for patients with a positive vasoreactive test during right heart catheterization. However, only certain subtypes of PAH are indicated for vasoreactivity testing according to the European guideline, and testing patients outside of these subtypes is specifically recommended against. Supportive evidence for the use of CCBs for PAH is generally graded as low-level evidence in these guidelines, and there are a variety of clinical scenarios for which CCBs should not be used or may not be favorable. For example, they should not be used for empiric treatment of PAH when vasoreactive testing cannot be carried out. They should not be used for non-vasoreactive cases or in the presence of right ventricular failure or contraindications to CCBs. And they may be unfavorable for certain subtypes of PAH where evidence is lacking. When patients with PAH are not candidates for vasoreactivity testing or CCBs, the FDA-approved agents for PAH should be initiated as clinically indicated. I'll refer to PAH drugs or PAH-specific therapies to mean those that are FDA approved for PAH, which does not include CCBs. So the guidelines differ somewhat according to how parameters for initiating therapy are emphasized. For instance, the ACCP algorithm specifies initial treatment decisions based on WHO functional class. For treatment-naive patients, the guideline recommends starting PAH drugs for patients presenting in functional class 2 or greater who are not candidates for or who had an insufficient response to CCB therapy. For patients presenting with functional class 2 or 3, initial combination therapy with ambrisentan and tadalafil is preferred, or as an alternative monotherapy with an ERA PDE5 inhibitor or riociguat are options. Initial parenteral prostanoid therapy is recommended for patients presenting with functional class 4 or class 3 with rapid progression of disease. Inhaled prostanoid therapy can be considered for cases where continuous IV or subcutaneous infusion are not feasible. As for the European guideline, initial treatment is based on the patient's mortality risk, which takes into account WHO functional class in addition to other predictive factors for poor prognosis, which I'll review on the next couple slides. Regarding patients who have initiated PAH drug therapy, if they have an insufficient response, then an escalation in therapy may be considered by adding on another PAH drug in a different class to proceed with dual or triple therapy. With the European guideline algorithm, PAH drugs are generally initiated when patients are not candidates for CCBs or after having an insufficient response to CCB therapy. Key factors that influence the recommended initial treatment approach include whether cardiopulmonary comorbidities are present, the patient's PAH subtype, and the patient's estimated 1-year mortality risk. This slide illustrates the 3 risk categories or strata, and the many parameters, including WHO functional class, that are considered to determine the patient's mortality risk and disease severity. Although treatment goals are individualized, generally the goal of therapy is to maintain the patient at a low risk for poor prognosis. The European guideline recommends initial monotherapy with a PDE5 inhibitor or ERA for patients with cardiopulmonary comorbidities and for patients with PAH associated with HIV or portal hypertension. Initial dual therapy with a PDE5 inhibitor and an ERA is recommended for patients with certain PAH subtypes who present in the low or intermediate risk category and who are without cardiopulmonary comorbidities. Initial triple therapy with a PDE5 inhibitor, an ERA, and an injectable prostacyclin analog is recommended for particular PAH subtypes presenting at high risk of death or intermediate risk of death with severe hemodynamic impairment and without cardiopulmonary comorbidities. Treatment decisions at follow-up are guided by the 4-risk strata multi-parameter assessment tool. Patients who are at low risk should continue their initiated regimen. Patients who are at intermediate risk can add an agent. For those in the higher risk categories, a parenteral prostacyclin analog is recommended, or if this is unfeasible, then other combination regimens can be considered. Over the next few slides, I'll refer to the current Medicaid prior authorization criteria in place for these PAH agents and considerations regarding appropriate management of this condition. The current PA form for PAH therapies requires a right heart catheterization and documentation of mean pulmonary arterial pressure. You may consider clarifying that it's the patient's historical pulmonary arterial pressure that is requested to support the diagnosis rather than their current pressure, which is dynamic and may be affected by PAH medication already initiated. Medical necessity may be considered for cases where right heart catheterization is contraindicated. For example, prescribers could state clinical rationale with other supportive laboratory findings, plus consultation with a provider at a PH center of expertise if applicable. The current PA form appears to require that all patients applying for any of the approved agents for PAH must first have vasoreactivity testing and have a previous trial of a calcium channel blocker. However, we should consider that not all subtypes of PAH are indicated for vasoreactivity testing, and not all patients with PAH may be appropriate for off-label use of CCB therapy. This criteria may be considered for removal, or alternatively, a field could be added to the form where the provider may attest that or express that their patient is not appropriate for vasoreactivity testing or CCB therapy. The PA form seems to allow patients to start one of these PAH agents only when they are in functional class 2 or higher. However, this criteria may not take into account the nuances of treatment experienced patients who may have improved to functional class 1, but who request a switch in therapy, either due to poor tolerability or when needing to transition from IV to oral therapy. Overall, this criterion may be considered for removal in order to ensure that patients are able to receive continued PAH therapy or tailoring of therapy to maintain an improved clinical and hemodynamic status, such as functional class 1. Alternatively, rewording the criterion may be considered to prevent potential misapplication to treatment experienced patients. Since PAH requires consistent lifelong treatment and sudden interruption in therapy can lead to exacerbation and hospitalization, you may consider extending the reauthorization frequency to every 9 or 12 months to minimize the potential for treatment interruptions. The requirement to demonstrate a positive clinical response at reauthorization may not be sensitive to nuances of the disease, such as the natural progression of disease and possible exacerbations, where an add-on therapy may be needed with continual background therapy. Aside from a 6-minute walk test noted on the PA form, consider that there are additional markers for improved disease severity, as shown in the mortality risk strata tables, and that approved indications of these agents span a variety of clinical outcome objectives. Regarding utilization in the fee-for-service adult population, last year there were 24 adults who utilized a PAH drug of interest, accounting for 127 total claims. Generic sildenafil comprised 37% of claims, followed by generic tadalafil with 26%, Opsumit 21%, ambrisentan 11%, and the remaining were less than 5% each. As for medical claims, there were less than 5 adults who received a PAH drug through medical billing. The 5 total claims were for Remodulin, Opsumit, and sildenafil. And that's all I have. Thank you very much for your attention. Let me know if you have any questions.
Kumar, did you have a question?
Yeah, I have my standard question. I'm thinking loud that number of patients is, kind of reasonable in terms of numbers, but what about the cost? I mean, is it like $20,000 or something like that per patient per year or something like that, or we're not allowed to talk about it?
Yes. I think you can safely assume that these therapies that are not available generically are very expensive.
Okay, thank you.
All right, we have some public comment. Kimberly Simpson, are you online?
I sure am. Good morning.
All right, we will turn some time over to you. You've got 3 minutes, and Brian does a fabulous job keeping track of that time.
All right, perfect. Thank you so much. Good morning. My name is Kim Simpson, and I'm a senior HUR liaison with United Therapeutics Corporation. Today, I'm going to discuss the latest clinical update for our inhaled treprostinil products, Tyvaso and Tyvaso DPI. In May 2022, the FDA approved Tyvaso DPI, a new formulation and inhalation device for Tyvaso for the treatment of pulmonary arterial hypertension, or PH, and pulmonary hypertension associated with interstitial lung disease, or PH-ILD, to improve exercisability. Tyvaso and Tyvaso DPI remain the only FDA-approved therapies for the treatment of patients with PH-ILD, a serious condition which furthers symptoms and decreases survival among patients with ILD. The FDA approval of Tyvaso DPI was supported by data from BREEZE, an open-label study of 51 PAH patients on a stable regimen of Tyvaso inhalation solution who were transitioned to Tyvaso DPI. In subjects with PAH, transition from Tyvaso to Tyvaso DPI demonstrated safety and tolerability during the 3-week treatment phase, with significant improvements in 6-minute walk distance, device preference and satisfaction, and patient-reported outcomes. Interim results of the optional extension phase suggest the improvement in 6-minute walk distance was sustained over 51 weeks. Patient tolerability, as assessed by the incidence of new adverse events following transition to Tyvaso DPI, was consistent with the expected known safety profile of Tyvaso. I'd also like to share published findings from a real-world analysis comparing Tyvaso and Ventavis, or inhaled iloprost, the 2 nebulized prostacyclin analogs approved in the U.S. for the treatment of PAH. Tyvaso is taken 4 times a day, while Ventavis is taken 6 to 9 times a day. Patients with PAH initiating Tyvaso or Ventavis were retrospectively identified in administrative claims data. Treatment adherence and persistence, healthcare resource use, and costs were evaluated in the 12 months following treatment initiation. Patients who initiated Tyvaso had significantly greater persistence with therapy at 6 and 12 months versus Ventavis. Specifically, at 6 months, 65.2% of Tyvaso patients compared with 35.5% of Ventavis patients were persistent with therapy. And at 12 months, 46.7% of Tyvaso patients compared with 16.1% of Ventavis patients were persistent with therapy. Tyvaso patients had a 29% reduced risk of hospitalization and significantly fewer hospitalizations and ED visits at 12 months versus Ventavis. No differences in healthcare costs were observed between persistent patients initiating Tyvaso or Ventavis. So given these findings, we ask that the Utah DUR board move both Tyvaso and Tyvaso DPI to preferred for PAH and PH-ILD patients that utilize your services for their medications. Thank you so much for your attention. I'm happy to take any questions.
Thank you. Couldn't find the mute button. Any questions from the committee? All right. Thank you. We appreciate your comments. Adrian, and I'm not going to try and pronounce your last name. I apologize. I get it wrong.
Oh, thank you, Dr. Cannon. Yeah, last name is Lau. Can you all hear me okay and see me okay?
All right, we'll turn the time over to you.
All right, perfect. Hi, my name is Adrian Lau, and I am a pharmacist and principal scientific account lead with Janssen Scientific Affairs. Thank you for the opportunity to speak with you about Uptravi, selexipag, Uptravi is a prostacyclin receptor agonist indicated for the treatment of pulmonary arterial hypertension, PAH, WHO Group 1, to delay disease progression and reduce the risk of hospitalization for PAH. Uptravi is available as a tablet for oral administration as well as an IV formulation for patients who are temporarily unable to take oral therapy. Now transitioning to some clinical and real-world evidence data overview. So in Griffin, a phase 3 study in predominantly functional class FC2 and 3 patients, Uptravi resulted in a 40% reduction in morbidity or mortality events compared to placebo. Adverse reactions that occurred more frequently in the Uptravi group were headache, diarrhea, jaw pain, nausea, myalgia, vomiting, pain in extremity, flushing, arthralgia, anemia, decreased appetite, and rash. In a follow-up of patients treated with Uptravi in the Griffin study, Kaplan-Meier 5-year estimates of survival were 71% and 63% at 7 years. In Triton, a phase 3b study, the reduction in PVR from baseline at week 26 was 54% in the initial triple therapy group. AEs were consistent with the known safety profiles of the individual medications. In a pooled post-hoc analysis of the Griffin and Triton trials, Uptravi decreased the risk of disease progression by 52% compared to placebo. The most common adverse events were headache, diarrhea, nausea, and peripheral edema. A retrospective claim study using the Optum database compared real-world hospitalizations in patients with PAH. Compared with oral treprostinil, Uptravi was associated with a 46% lower risk of all-cause hospitalization and a 47% lower risk of PAH-related hospitalization. A model study was conducted for patients managed with Uptravi or oral treprostinil from a U.S. commercial payer perspective, with a population of 1 million over a 2-year horizon. An estimated 78 PAH cases would be eligible for treatment with lower total PAH-related and all-cause hospitalization costs for Uptravi than oral treprostinil. For these reasons, please consider adding Uptravi to the Utah Medicaid Preferred Drug List. Please refer to the full prescribing information for complete information. Thank you for your time and consideration today.
Thank you. Does anyone have any questions for Dr. Lau before we let him go? Okay, seeing none. Thank you, Dr. Lau. We appreciate you taking some time to speak with us today. So we now have committee discussion questions, and really, I think this is intended noon for us to review the current prior authorization criteria. Is that correct?
So Dr. Cannon, since we will have, this is like a series, this is the first series of the PAH in adult, and we will have a PAH review in children for next month. So at the end of next month, we will review the PA altogether, since the PA will be including both adult and children's criteria.
All right. I like this so far. It's going to be a nice morning. It's blue, sunny skies. So are there any questions or comments from the committee as it relates to what we've discussed today around adult pulmonary hypertension? Kumar?
How about the incidence of this in regional locations like Idaho or Colorado or one of those places? Are the numbers similar to what we find in Utah?
I don't have information on even what the incidence is in the U.S. All I could find, because this is a rare disease, all I could find was the incidence based on European registries. So yeah, but like we kind of saw how many patients in the fee-for-service seem to be on this. But we didn't have time to go through ICD-10 coding. So some of these, I don't know if, some of these have multiple approved indications. So some use may be for ILD or the approved products. but total we had 24 adults in the pharmacy claims on these agents.
See, I was just wondering if it's a regional, thing, or is it, national, or whatever. Neil, you have a comment? Your head. I was watching your head. Oh, you don't. Oh, okay.
I think Dr. Weinstein's got her hand up though.
Oh, I thought maybe Michael was first. But thank you.
I can't. Okay, I see Michael now. Sorry about that.
It's okay. I'll try to be brief. Just first a technical question, then a comment. So this is not my area of primary specialty, but I do see a lot of patients with this condition being in palliative care. And what I'm wondering is, having looked at that, first of all, beautiful presentation, Valerie. This is a very complicated condition, and clearly with all these different medications, that comprehensive table that seemed to be, very updated with all of the indications and the different medications. Is it our task then, this is the process question, to kind of look at the PAs vis-a-vis the table and kind of see where we are to, position everything and make sure we've got, all of the latest recommendations kind of built into the PAs? Is that kind of what we're doing at this point? I was a little overwhelmed with the complexity of this and what our task is, and do that kind of with the adult side and then the pediatric side. It seems a little complicated to me what our task is. So that's the question. Then the observation is, we have a couple of things that complicate pulmonary treatment, obviously altitude, but I think we're going to see more and more patients who have interstitial lung disease and other pulmonary complications that would add to the indications potentially with post-COVID. So that's the observation. And thank you for letting me go.
Thank you, Dr. Weinstein. And yes, I would recommend to review the PA at the next meeting, and to help, since it will be like a couple of weeks between the two meetings, I can send out the presentation that Val did today for the adult to the board, so that we can keep track of the recommendation from the DRC for today for the adult, and then compare with the recommendation from the DRC next time for the pediatric, if that would help the board to follow through and with the PA criteria.
Thank you. I think it would, because it's enormously complicated condition with all the subtypes and the different meds that we have now in guideline, and with all the evidence, there's a lot of subtlety, and things have changed considerably as things come through. So I would find that helpful for one. Dr. Cannon?
Noon, could you please include the current PA that's available to look, so we can look and see what's in there? That'd be really, really helpful too.
I will. Thank you, Dr. Catalano. And look like we have other people who would like to speak.
Dr. Smith. I think we just lost Catherine. All right.
There she is. She's muted.
Now she's back.
Yeah, Michael had a question before me.
Yeah, and I think we need to make sure we've got a conflict of interest on file from Michael, since he works for Merck. And so I'll leave it to him to work with Noon to take care of that.
Okay, well then, can I ask my question real quick, I guess?
Yes, you can.
I saw the part in the recommendations about people being managed by pulmonary hypertension specialist. And I was just wondering, do we have that in Utah? How many, are most of our patients being managed in specialty centers, or are they more in line with what's in our PA, which is cardiologists and pulmonologists? just maybe for discussion at our next meeting.
I think that'd be a good thing to understand. My experience has been that most of them are seeing pulmonologists.
This is Joe. Valerie's review points out that there are 2 centers of excellence in the state of Utah for PAH, the U and Intermountain, I think, Valerie.
Yeah, thanks for pointing that out. I haven't dug through the types of prescribers, though that would take quite a bit of time to see who wrote those prescriptions and their affiliations. But yeah, in the report I do reference a couple centers that are considered specialty centers here. But yeah, they do seem Salt Lake based, so I'm not sure if patients in rural areas have access, or I hope at least their pulmonologist or cardiologist there is maybe consulting with the center here.
I can answer that question. If excuse me for interrupting, but I used to work in a PAH clinic, and yeah, the rural patients are managed at the centers of excellence, and where possible, coordinating with their local providers. But the providers who are working in these centers of excellence are pulmonologists who specialize in PAH. Typically, you also can see some cardiology involvement as well because of the disease state, but it is a pulmonologist working at the Center of Excellence who manages all individuals in the state, and then they try to develop treatment options that work for the individual who's living in rural locations, so that if, for example, they were to lose a central line or something with some of these continuously infused therapies, there's ways to get immediate care. So there's a lot of thought gone into that, and certainly really detailed approach because of the complexity of the disease.
All right, Dr. Brenton.
Yeah, I was just, oh, come on. Hey. I don't know how to do this camera thing. Okay, I was just going to say, I was curious about whether, I know Senator Hinkins, who's in the Carbon-Emery area, ran a Senate bill that passed this year to allow telehealth for these chronic patients. I just wondered, maybe these will be patients that can also benefit from that. I just thought, as the technology advances, it's so nice to be able to have their centers of excellence be able to coordinate with physicians and with with patients more rurally. I just thought maybe this is another group that will benefit from that. So just thanks.
Thank you. And then Michael, I'll leave it to you to work with Noon to get a conflict of interest on file, and then we can hear from you.
Yes, Michael, if you would like to send me a COI after this meeting, we can have you provide a public comment or question at the next meeting for the PAH insurance.
All right. With that, I don't see any more questions. Before anybody else can ask another one, do we have a motion to adjourn?
So moved.
Second.
We have a motion and a second. All in favor?
Aye.
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 Great. Hey, thank you, everyone. Have a great day. Enjoy the sun while it lasts for at least a day, huh? All right. Bye-bye.
Bye,
Take care.
everyone. Bye-bye.
Bye.